Good morning. My name is Alexandra Lansky from Yale University, and it's my pleasure to be here today with Dr. Otavio Berwanger from Research Institute of São Paulo in Brazil. And we're here to talk about the BRIDGE-ACS trial. So I'm wondering if you could give us a little bit of background about your study.
Well, thanks very much for inviting me. The BRIDGE was designed to fill the gap that exists between evidence and practice. As you well know, unfortunately, registries conducted in several countries, including Brazil, US, Europe, have shown that physicians don't follow guidelines quite completely. So we approached the Brazilian Ministry of Health, and they funded our initiative, which was a cluster randomized trial in which we randomized 34 public hospitals in Brazil. 17 of these hospitals were randomized to a quality improvement intervention, a multi-facet quality improvement intervention, including reminders, including a case manager, including an easy-to-follow checklist. I mean, these are all complex interventions, very different from giving a pill, but we try to keep as simple as possible, or in the other 17 trials were randomized to routine practice. And the primary outcome was really to assess the effects of this quality improvement intervention, the uptake of evidence-based therapies, not only during the first 24 hours, but also during the first 24 hours and at discharge.
So what specific quality improvements did you look at?
Well, we focus on evidence-based medication. So during the first 24 hours, the use of aspirin, anticoagulation, with either low molecular heparin or fractional heparin or fondaparinux, antiplatelet therapy and statins. And during the whole hospitalization, we focus on all 1A American Heart and ACC guidelines. So all the acute therapies plus discharge medications such as ACE inhibitors, statins, aspirin, and beta blockers for patients with post.
And how many patients did you evaluate?
We included 1,150 patients from these 34 clusters.
And what were the main findings from your study?
Well, the findings were very interesting in terms of using the acute therapies compared to clusters randomized to the control group, clusters randomized to the quality improvement intervention group. We observed a 18% increase in the uptake of all eligible evidence-based therapies, and we also found similar results during the whole hospitalization, and 19% increase in the use of all eligible evidence-based therapies during the hospitalization. We also measure clinical endpoints. We were really, cluster trials require a large number of clusters to assess clinical endpoints. So these were secondary endpoints. We were not statistically powered to assess that. Nevertheless, we found all the point estimates for major cardiovascular events, cardiac arrest, stroke, new myocardial infarction were all in the right direction. And we found just bleeding that we found in the opposite direction, but that is expected since we were stimulating the use of antithrombotic therapy.
So what are your recommendations then to institutions in South America as well as North America to improve compliance with these guidelines?
Well, I think our study shows that if you use very active interventions, such as reminders, such as identifying a committed person as a case manager, use of an active checklist, it's possible to really improve clinical practice. So I believe our intervention does not rely on very expensive technology, so it's really applicable to several types of hospital. Nevertheless, since our study was conducted just in Brazil, is our goal we're planning a BRIDGE-ACS 2 trial involving several countries, and we're trying to seeking funding for that, but it's very likely based on the JAMA publication that will be possible. And then this time accessing clinical events and improving, of course, our intervention.
Okay, well, I want to thank you. This is very exciting work you're doing. I want to thank you for joining us today. And that concludes our interview.